Is it this one? We'll check it first. This is the right one, is it? Thank you all. Thank you for the invite and allowing me to talk to you about LINX in bariatric surgery. Yeah, we've got the post-lunch lull, but probably in 10 minutes is when the sugar's going to drop, so that's probably about the time I've got. So what I want to do is just sort of run through, really, where we are with LINX. I've been doing LINX for sort of 6-7 years now. Certainly my go-to procedure for reflux and reflux in bariatric surgery, but just to give you a flavour, really, of where we're up to and what we've learned over the last decade or so, and just give you a bit of my personal experience and where I think the future of LINX is, and answer any questions that you might have. So just a bit about me. I'm a bariatric cancer reflux surgeon for the last 12 years or so. I do around 50 reflux surgeries probably a year. I've put in over 100 implants and probably now about 20 plus in bariatric surgery, which doesn't seem a lot, I know, but I'll kind of explain a bit why that is. Just disclosures, I've worked for J&J. So quick straw poll, I'm not going to make you put hands up, but just there's probably a few people you're going to fall into this room. I would have thought either people in here implanting LINX already and doing it post-bariatric surgery, people that may be just interested but not doing it and like a bit more data, people who are not LINX surgeons, and lots of people who think it's probably just stupid. But I'll try and convince you otherwise from that point of view. So just background on LINX, it's important to remember it's been around a long time. 2004, first original design, and then really pivotal studies published 2007 and 2009. Lots of change really around 2018, 2020 when the FDA removed precautions, NICE guidelines came in, removal of precautions around hiatus hernia. So it's escalated up over the last sort of 3 to 4 years, partly really, as I said, with Johnson & Johnson taking over from Thorax in 2017. Important to remember as well from our side in the UK, it has now NICE approval, so it is in standard arrangements, so there's enough evidence and data for LINX to use it as the first line procedure for reflux. So that's an important thing, particularly if you're trying to get into a hospital within an NHS practice. So just through some of the evidence, we have touched on it a bit this morning. I'll go through it in a little bit more detail. I know some of the colleagues this morning have sort of gone through it, but really, first trial was published in 2013 by Gantz. It was 100 patients. First implant going in 2009, 3-year results in the New England Journal. And really just looking at whether it was safe and efficacious to do it. And around 90% of people have reduction in PPI use of 50%. As I said, Ethicon took over. Changes then moving forward, 2018, originally LINX, if you remember, was really not licensed for hiatus hernia surgery, it was just primary anti-reflux, but the precautions were removed in 2018. Some of the landmark trials, what have we got? So I'm not going to bore you with it all, but it was Bell's group showing LINX, a randomized trial versus BD PPI, 50 patients and 100 in the PPI group, and looking at GERD, HRQLs, LINX versus BD PPI, 81% versus 8%, with 92% of patients actually coming off their PPIs at that point. When you're looking at healthcare questionnaires, lots of data suggesting its efficacy and actually continues to improve with time. And then you look at actually objective measures, acid exposure, plenty of studies done, but the main ones from Bonavina and Lipham, and actually looking at post-LINX and pre-LINX and post-LINX and actually seeing normalization of acid exposure in plenty of studies. When we compare it to Fundo, similar results in effect in terms of people's healthcare and acid exposure, which shows it at least as good, but potentially a lower revision rate. Now this is going to be a bit down to surgeons, a bit patient selection, so it's slightly heterogeneous, but overall revision rate for LINX is staying relatively static at 5 to 7%, potentially higher with fund applications. So on to the nitty-gritty really of why we're here, because obviously this is a bariatric symposium. When we talk about weight, and we always worry about hiatus hernia surgery and weight, but actually if you look at the data with LINX, this was John Lipham's study, which has allowed me to use, and he did a retrospective cohort with 600 patients and separating the groups out and looking at their BMI of under 25, 25 to 30, 30, and then 35 above. And if you actually have a look in terms of their GERD scores and their DEMESA scores, there was no difference between the groups in terms of weight. So, are you waving at me or waving at him? you want a cup of tea or something? No, you're all right. No difference in terms of weight between the groups. So actually, LINX seems to still be effective irrespective of BMI. And it's probably about the mechanism of how it's working. Worldwide experience now. I really just show you this because now well over 50,000 implants, probably more like 68, 70,000. Procedural complications, reversal rate is staying about static. Most of the reversals or change is about 50-50 split between patients having persistent dysphagia or patients having ongoing reflux. Safety profile, erosions that we all worry about, is staying static about 0.3. So between 2,500 to 60,000 implants, there's no real change, which I think is very reassuring. So what about with bariatric surgery? As I said, we've touched a little bit on this this morning. First reported by Ben David, 7 patients, really 7 patients, but it's in the literature showing it was safe and it was effective. And then since then, the main trial we touched on this morning was the RELIEF trial that was presented at ASMBS in 2022. And this was an observational study, multi-center, 30 patients, looking at assessing patients with OGD, pH manometry and barium swallows, then following up 3, 6, 12 months and looking at the GERD scores. I'll just make a note a bit on the LINX size. I may touch on that in a moment because it may explain some of the data, but they were ranging from 14 to 17s. That's not been my experience in bariatric surgery. 16, 17s, 18s that don't exist. And I probably would have liked 19 at some point, but none of those exist. So, but that's the data. And what does it show? Well, a mixed bag of results, really. But overall, around about half of the patients actually had 50% reduction in their acid or normalization. 50%, and if you look at the patients that actually had a 50% reduction in their PPI use, around 95%. And 84% of patients actually came off their medication completely after a sleeve. Regurgitation is a big thing. LINX is great for regurgitation on the whole, and you look at regurgitation events, dramatic reduction post-LINX at 12 months after sleeve. And actually overall, satisfaction was good at 70%. So despite that mixed result, patients were happy and it seemed to do them some good. Adverse events, 21 in total, most of them pretty minor, some dysphagia, some pain. There was an explant in 2 patients for dysphagic reasons. And I think that probably comes back potentially to some of the size of the LINX that they were using. I have never managed to put a 14 or 15 in anyone post-bariatric surgery, and I think that may answer some of those questions. The same group as LINX TM, followed this up with some long-term data. I just say a bit of caution to this because it was a little bit, it's not quite sure how the patients were selected, but there were 16 patients from this group, a mixed bag of some sleeve and a couple of bypasses. Median follow-up of 48 months. And all the patients had a good normalization score at 12 months. But again, a bit of caution on this because this patient selection is not quite clear. But again, if we look at 3 years, reflux regurgitation almost back down to 0. There was a systematic review by Bonavina. Can't see from that on, it's not. Yes, it was. Looking at 109 patients, 14 studies, median follow-up of 19 months. Again, a slightly heterogeneous group. But overall, what could be pulled out from that was a reduction in daily PPI use to 25% from 97%. 8 studies included did show some HRQL and a significant reduction in those too. Adverse events, similar, around 11%, mostly fairly minor. It's dysphagia, some pain and some slight sickness. Broken device, I have no idea how you do that, but there you go. And there was one erosion. They came up with an algorithm, which I won't go through in too much detail for speed, but it's fairly simple, straightforward, and stuff that you would just do in your normal practice. Really scope the patients, look at them, any dilatation, you're going down the achalasia group. I'll touch on this in a minute. This is the most important thing, looking at the sleeve anatomy and any concerns, maybe thinking of other options. And then coming down this column, if the sleeve anatomy is normal, I take a slight umbrage a bit with this. They separate out the BMI category, but I've always shown you that the BMI is irrelevant with LINX. It's still effective. So yes, I agree with that if the BMI is over 35, but that's down to patient choice. Actually, do they want to lose some more weight? Not for me about whether they've got reflux or not. Sleeve morphology, really important. Nice sleeve at the top. All of these, no one's going to go near, I'm sure. At the end of the day, you're fighting physics with the LINX, and you can't keep making the OGJ tight when you've got these sort of problems. So a big fundus at the top is not going to work. Mid-sleeve stricture, it's not going to work. Tightness in the incisura, it's not going to work. These obviously need revision, but it's really important. So my personal view, so important with sleeves, assess the morphology. An OGD is not going to be enough. Double contrast barium swallow with some gas, with some marshmallow, and look and look and look. An OGD is not going to pick up those subtle points. There'll be a problem. Normal colour esophagus, regurgitation symptoms, and a low pressure across the LES is good. Patients to avoid anyone with a dilated esophagus, poor motility, severe reflux, it's not going to be as effective. So the grade C D esophagitis, it won't be as effective. Quickly on bypass, just last 2 slides, very little evidence, limited role in RYGB. I've wanted to do it more. I definitely do it more in OAGBs because I tend to find with the OAGBs it's definitely more of a problem with the hiatus or a problem with the stoma or a problem with the JJ. And you've got to sort that out first before thinking about putting LINX in. Take into fact, what is the reflux? Is it bile? Is it acid? What are the patient factors? Are they happy with their operation? Patients have a sleeve and they're happy with it, it's working well. If they're happy with the bypass and it's working well, they don't particularly want to have that, in my view, converted to a different operation. If it's reflux, try to deal with the reflux first if you can. For me, everybody gets endoscopy, double contrast barium swallow with bolus, high resolution manometry and pH studies. Look hard for SIBO. SIBO contributes to reflux. It's very common in these patients. They're your low-hanging fruit. Regurgitant symptoms, a little bit of esophagitis, small hiatus hernia, and a normal-looking anatomy. I personally look to revise sleeves, or I look to work on the hiatus before converting to bypass. I think once you've done an RYGB, you've done it. There is no coming back from that. And if you haven't solved their problem, you're a bit stuck. That's just my personal view. And it's generally my default for an OAGB now is a LINX and sort the hiatus out, manage patient expectations. So in summary, LINX post-bariatric surgery is effective, it does work, but get it right first time. I think we've gone on about it before. If you get the sleeve right first time, you're probably not going to have as much reflux. Certainly in my practice when I started, I was probably repairing hiatus hernias in sleeve 10% of the patients. I think I now do it 50% of the time. They don't have more hiatus hernias, I'm just looking harder. Do nothing with these patients for at least a year. Be meticulous at proving reflux. Be prepared to change. I say this because of the 20 or so I've put in, I've probably listed 40 people and I've only implanted 20 because at the time of surgery the esophagus is too big, the anatomy is not right, I don't like the look of it and I haven't done it. Manage people's expectations and pick your low-hanging fruit. Whistle stop tour. Any questions, don't hesitate, let me know. Thank you.
Thank you.